Good evening. Very, very happy Doctors' Day to all our dedicated doctors who have joined today for the sixth session of Tuesdays with Teachers. Um, Today is a day each one of you must have received wonderful greetings, wishes, words of appreciation, cards, and flowers to say how grateful our patients, their families are to the years of dedicated work that we have carried out. And I would say it is a time that we should celebrate our own selves and reiterate our commitment to healing and caring of our patients so that we can really make a difference in the lives of of our patients and our own selves. Nothing more validating than having a heartfelt thank you from a satisfied patient. So I wish on behalf of Tuesdays with Teachers, all my teachers, all my moderators along with me, join you all in wishing you a very, very happy Teachers' Day. And today, we have changed a little bit of sequence. I'm not going to let my moderator introduce me because you all know me. I would like to do the honors of introducing my moderator and my speaker for the day. So the moderator today is Dr. Rinku Sen Gupta. For me, all of these people are young. They are my juniors. Next, Rinku. But it's my duty to introduce Dr. Rinku to all of you. Well, she's the moderator and she is a very senior consultant in Holy Family Hospital. She's chief of their Holy Family Hospital and Rainbow Hospitals in Delhi. And her areas of interest, especially, are decreasing interventions in obstetric care. Apart from, her clinical accolades, what I loved about Dr. Rinku is that she's a thoroughly ethical obstetrician. And that is a disappearing breed, I should say. So I feel very proud in, presenting Dr. Rinku to you all today as our moderator. And then the speaker for the day is Dr. Niraj Yanamandra. And I always believe in destiny, so somewhere I will bring in God. But it was divine intervention that I met Dr. Neeraj in Hyderabad. I heard his clarity of thought and the way he presented CTG, and something which is so important. So, well, you will know the way he presents his talk. He is a fantastically well updated clinician, obstetrician, and an endoscopic surgeon. I do not know, Neeraj, when I will get the opportunity to present your this skill, but yes, your interest in high risk obstetrics and your contributions to, improving understanding of CTG is there for all of us. He has been trained in UK and is in addition to everything, he's a fantastic human being. So, friends, the topic for today is something all of us know, CTG. So, well, we all know monitoring is extremely important. And as a theory question, I can say that each one of you will be able to score 10 on 10 on writing all the features of CTG, this and that. But the problem happens that when we are in isolation of our own practice with our own patient, and then there's nobody to, question or can confirm our findings, that is this normal, is this abnormal, what should be the next step. So today's session is totally dedicated into two phases. One, when Dr. Neeraj will take us through the understanding of CTG, and in the second part, Dr. Rinku will be taking us through graphs so that we have a better understanding and we are able to put it in clinical use. With that small introduction, and my 5 minutes are over. Over to you, Dr. Rinku, to set the ball rolling. And now
Yeah.
I'll go on to
Thank you.
my happy job of admitting everybody. Welcome and happy learning, everybody.
Thank you so much, ma'am. And thank you for this opportunity. Now, cardiotocographs are like our soulmates in obstetrics, we think we know them all, but then suddenly there is a surprise. All through our career, we face this sudden surprises. And we know that this investigation is not such a perfect tool. And it is only a screening tool, not a diagnostic tool. That is a very, very important aspect that we have to always remember. Hello.
Yeah, what happened? Hmm.
I don't know, the sound is echoing.
कोई
So,
दो ठीक
the
है.
cardiotocographs have a high false positive rate, and that is a very huge limitation with cardiotocographs. And although they're very sensitive, in modern obstetrics, we want them to be more sensitive. We want to reach a perfect 10 always. And as clinicians, you all know what I'm talking about. You know, I call the cardiotocographs the homographs. That means two words which look alike, sound alike, but mean completely different things. You look at the graph on the left side. There is this mother who came for a routine NST for induction, and then she was put on the admission test. And you see this sharp tooth pattern on her CTG. And on the right side, there's this mother who came with decreased fetal movements. Both are showing a similar kind of a graph, but they had radically different outcomes. The one on the left finally went on to have a normal CTG and a normal labor, and she delivered with good APGARs. And the one on the right finally had a C section and fetal anemia and fetal-maternal hemorrhage with a poor APGAR. So you know exactly what I mean. With CTGs, there are so many confusions, so many doubts, and we have to look beyond the anatomy and morphology of the CTG. So Dr. Niraj, please come in. The floor is all yours, and I'm sure you're going to clear a lot of the doubts in our minds. Please. I'll stop sharing.
Yeah. Have you stopped sharing? Yes. Yes, I believe my screen is seen. Is it?
Yes,
Yes.
yes.
Yes. Good evening, everyone, and a happy Doctor's Day to all of you, hardworking obstetricians. And thank you, Mitra Madam, for the wonderful words you said. I don't know whether I deserve all of that or not, but thank you. And now we're going to talk about decoding the intricacies of CTG. CTG is a very, very large topic. We can talk for hours on it, but I've tried to bring in some important things, including certain new concepts in the next, whatever, 40 minutes or so, which I'm going to talk on. If you have any questions or anything, please do write down in the chat box. And if as and when we have time, we'll try and address them. So my screen is not changing.
Take it there on the left lower and move the
Yeah,
arrow.
got it. So before we actually get into the CTG and the intricacies and the delicacies of it, we'll first look at certain basic physiology of human body, including adults and the fetus. Now, what determines the normal fetal heart rate? First thing when we look at CTGs, we talk about what is the fetal heart rate of this particular CTG. Now, we all know that autonomic nervous system constitutes of sympathetic and parasympathetic nervous system, and this controls the visceral functions. Sympathetic, from medical school days, we all know it is flight or fright response, and it is essential for survival. Parasympathetic, on the other hand, has more calming effect. It is responsible for bringing down the heart rate, and it reduces fetal heart rate to maintain positive energy balance in the heart. We'll talk about positive energy balance in the next slides. So they are constantly interacting with each other. Sympathetic, parasympathetic in all our bodies is constantly interacting with each other. And if you can say so that there is an agreement which is reached following this interaction, and that agreement is what is baseline fetal heart rate, and that applies to even us. Now, what is baseline variability? I'm sorry if I'm taking through very basics, but I think this will build up the whole story. So baseline variability, it is a constant fluctuation, which I just said, between sympathetic and parasympathetic, creates a bandwidth of the baseline, around the baseline. And that we say is baseline variability. Here, I would say now, please stop using words or terminologies like beat to beat variability, because beat to beat variability is not anymore used. It is baseline variability we'll talk about. And no short-term variability, long-term variability, that also should not be used. It is baseline variability. Somatic nervous system, it is a voluntary control of our body movements. I'm moving, I do anything, my body is moving, that is somatic nervous system. And it accounts for accelerations, particularly in the baby as well, and includes us as well. Now, when a fetus starts its journey of a normal labor through the birth canal, for us, it is an everyday thing, but for a fetus, for that particular fetus, there are so many challenges at the start of the labor itself. If you look at it, there's nothing in his hands, in that baby's hands. The external environment, whether it is a nice daytime laboring mother with all the help available, all the seniors available at 100% efficiency, or it's at 2 a.m. in the middle of the night with the junior most person on labor ward and that mother is laboring. Things can go wrong, and there is enough evidence in literature also. I think there was a paper in BMJ some long time ago which was something like dangers of being born in the night, which means all mishaps or most mishaps do happen in the night, where there's increased morbidity and mortality for the baby, perinatal mortality and morbidity, because of the fact that seniors are not there and so on. The maternal vascular disease, whether she's having preeclampsia, whether she's elderly, we don't know. That is, again, which is something which baby has to deal with. I'm not going to read through all these, but if you have a brief look at it, you will realize that there are so many challenges which the baby starts with at the beginning of labor, and therefore nature has to provide it with certain armamentarium, if I say, or certain ammunition for it to handle all these pressures and try and achieve a successful normal delivery. Now, this was a chapter which I wrote with Professor Sir Sabratnam Arul Kumran. This was published in one of the recent advances series, and wherein we had looked at intrapartum fetal monitoring towards improving perinatal outcome, and we looked at various tools which are available to us, including clinical surveillance, biophysical, and biochemical. Now, these are the various tools that we all have, which we all use depending on where you're working and what kind of patient you're dealing with. But for the sake of this talk, I'm going to restrict myself to electronic fetal monitoring, which is CTG. Now leave this, put a pause button here for a minute, and now consider ourselves, all of us adults sitting here. We all know that myocardium, our heart, is the pump. If you imagine that as a pump, we know that if the pump fails, every other organ in the body is going to fail. The next most important organ in our body is the brain. Now nature, and this fact is exemplified in the way our anatomy is laid. The blood from left ventricle, which is fully loaded with oxygen, fresh, full loaded blood, when it leaves the left ventricle, first branch it gives is to itself. First, it looks after itself. First branch, coronary, goes to heart. The second branch goes to brain from the coronary. So even nature has designed our bodies where heart first and brain second. Once these two organs are taken care of, rest of the body can be taken care of. In fact, it is the heart first. It has to look after itself first. Now, what happens when we all do anything stressful? This can include anything like a physical activity. For example, I'm on a treadmill and I'm running. What happens? My need for oxygen goes up. My heart rate increases, the force of contraction increases, and there's increased demand of oxygen by my heart. Now, if this oxygen demand is not met, then there is a risk of myocardial hypoxia and acidosis. To meet this challenge, how is my body designed? How is our bodies designed? The first physiological response we all have is on respiratory rate. The rate and depth of respiration increases. I start taking in more and more oxygen because my body needs now more oxygen to protect the myocardium. And therefore, this myocardium, which is the main pump, has to have positive energy balance in it so as to work effectively. First, look after itself, send it to brain, and then send it to other organs of the body. And associated with this, there's tachycardia. That tachycardia is because of release of catecholamines. The adrenals, the small glands, but they're beautiful. They release catecholamines in stressful situations, which is adrenaline and noradrenaline. There are three functions which these do. One is it increases rate and force of contraction. It causes peripheral vasoconstriction, shutting down the supply to peripheral organs, and glycogenolysis. By glycogenolysis, there's increased energy substrate, which is available in the myocardium to keep working in the stressful situations. That's about adult. What happens in fetal physiology now? When you draw that parallel in the fetus heart rate also is controlled by autonomic nervous system. Sympathetic increases, parasympathetic decreases. Adrenals release adrenaline and noradrenaline, and somatic nervous system, which is where the fetal movement we talk about, the accelerations with fetal movement, which we notice on the CTG, is because of somatic nervous system, which is there in the baby. And we always feel very happy and satisfied that the accelerations are seen. That is because that tells us that this baby is playing football inside, happy baby, leave it alone, it's kicking in, all the systems are perfect. You see the acceleration, you see fine, stop the CTG and send her home or whatever, depending on the situation. Now, the same baby, when it becomes hypoxic, what happens? Why do we ask about fetal movements? Because when it undergoes hypoxia or faces stressful situation, First, it reduces its movements. It's the same as me. If I am taking stairs of my hospital and I go from ground to 4th floor in 1 minute, for example, if I'm unwell, I may take 2 minutes. First thing, what will I do? I take rest after a few steps. I sit down, I gather some energy, go up few stairs, sit down, gather some energy and go up. So what am I doing? I'm reducing my wasteful movements so as to maintain positive energy balance. Therefore, there comes the importance of baby's movements, because if the baby is moving less, we say that the baby may be in trouble because it is trying to conserve the energy. It is the same me who's having viral fever, not able to walk as I would when I'm absolutely fit and well. This is very basic. Reduced oxygen saturations in fetus. If it is in the blood, it is hypoxemia. If it is in the tissues, it is hypoxia. And oxygen deficiency in any of the central organs, such as brain, heart, adrenals, very important organs, 3. Brain and heart, we already said, adrenals. And with loss of energy balance, if there is metabolic acidosis, then this is termed as fetal acidosis. Now, the benefit which we have, unfortunately, the baby doesn't have. It starts with 2 huge disadvantages. What is it? 1, it is immersed in a pool of blood, so it cannot breathe. The oxygen which is available for you and me from atmosphere is not available for the baby because it is immersed in pool of fluid, so forget about that. Second, the baby does not have the capacity to increase its stroke volume. It cannot increase the force of contraction of the heart as we do. So our cardiac output increases by 2 ways. 1, increasing heart rate. Second, by increasing the force of contraction. This baby will only be able to increase the force of the rate of heart beating, not force of contraction. Does not have oxygen available from atmosphere. So it has to solely rely on the cardiac output by increasing its heart rate. There comes the tachycardia of CTG. So when you see CTG tachycardia, you start thinking, oh, is this baby getting distressed? Is this baby getting hypoxic? So that is where lies the role of fetal movements I've said earlier. Then I've said about how the heart rate is what is solely baby dependent upon to help increase its or meet its demand. But you have to admire nature, that how the baby is actually equipped to deal with these problems. It attempts to protect its brain, heart, and adrenals. Now, the way the physiology is designed, baby's liver, kidney, and lungs, baby doesn't have to bother at all because that is being looked after by the placenta. Now, when the baby is getting hypoxic, it shuts down its peripheral supply, which means it shuts down the blood to skin, scalp, and gut. So what remains? All the blood is redistributed to brain, heart, and adrenals. So that is how the baby physiology is. So whenever the baby is getting hypoxic, these 3 organs are looked after. Everything is shut down. Liver, kidneys, and lungs are looked after by the placenta. And baby reduces its energy activity by so as to conserve energy, which is what I've already said. It has hemoglobin F, which is beautiful because it can mop up extra. It acts as a buffer, which I'll show you in the next one, and it releases catecholamines exactly like we do as adults. It increases, and these catecholamines have 3 functions again: increasing heart rate, causing peripheral vasoconstriction, and causing glycogenolysis. Now, in hypoxia, fetal hemoglobin kicks in beautifully well. The hemoglobin levels are 18 to 22, and it acts as buffer during acidosis, and it releases oxygen in low oxygen tension. It has increased oxygen carrying capacity, and it has increased affinity for oxygen. All this helps baby to deal with the challenges of hypoxia, although it does not have the benefits which we have as adults, which I've already mentioned. And again, predominantly by increasing heart rate is what is the mechanism of baby trying to meet its extra demand. And redistribution, I've already said about that. So now if you think of it, the problem with CTG is when it was introduced, it was a good scientific basis it was introduced upon. But there was no studies, there were no randomized trials, there was no studies in fact introduced. It was a technology which was introduced into practice without any trials. So anything which was seen on CTG in terms of morphology of the CTG, morphology when I'm saying deceleration, for example, it created anxiety and panic amongst obstetricians, and they came up with various terminologies, including late decels, early decels, type 1 decels, type 2 decels, and so on. But what we have not realized at that time was that deceleration actually is a cardioprotective mechanism of the body, of the fetus, where it is trying to reduce its workload, myocardial workload. So it will reduce, so it will need less energy, and it will conserve more energy to maintain the positive energy within the myocardium. And it will also allow diastolic filling. So deceleration, when you see on CTG, please do not panic. You think this way that the baby is now trying to kick in with its first or second protective mechanism by reducing the heart workload. So the heart needs less energy. It allows more diastolic filling of fresh oxygenated blood or whatever it gets from the mother, and it will then go up to the baseline to grab more oxygen and then goes decels down again so as to conserve the energy. So it is essentially a cardioprotective mechanism and not deceleration, which you should start panicking about or getting anxious about. One of the most important things of fetal CTG is cycling. If I see the first 15-20 minutes of the CTG, I'll think, no, this is not normal. This doesn't look right. But this is a quiescent state of the baby. Immediately after that, you can see how the baby is awakened and the accelerations are beautiful. The variability is beautiful. The heart rate is normal. So if you have absence of cycling, then that should worry you because that can be seen in various conditions, which I've written down there. Now, oxygenation from fetus point of view, we have looked at this, but again, in a chronically, for example, fetal growth restricted baby, the placental blood supply may not be good enough. There may be preeclamptic mother whose blood supply may not be good enough to the baby. Dopplers may be affected. Integrity of the umbilical cord, for example, is there a true knot in the cord? Whether the baby has normal oxygen carrying capacity, whether the brain and heart are structurally normal, whether it has intact CNS, whether it has intact fetal stress response. These are all things which the baby is not kind of aware of, or it's not in anybody's hands. But these are the factors which eventually will come into play at particular time in labor. So when you talk of decelerations now these red things which I have said, we'll elaborate more about it, but I've just written down here quickly. So I'll tell you what it means and where it comes from. But when you talk of deceleration, there are two types of decelerations. One is baroreceptor stimulated. Second is the chemoreceptor. The baroreceptors are situated in carotid sinus and arch of aorta. They send impulses to cardiovascular center, which increase parasympathetic drive via vagus and sympathetic drive. So these baroreceptors, which are in carotid sinus and arch of aorta, are stimulated by occlusion of umbilical artery, and these are called as quickly. The decelerations which you see, they are abrupt drop in the heart rate, then they come back to normal. The abrupt drop and coming back to normal. So these are baroreceptor stimulated. They're short-lasting insults related to uterine contractions. They quickly return to baseline, do not cause hypoxia. In the absence of any other abnormality, leave the baby alone. No intervention is needed, just observe. So looking at that CTG, I'm sure most of us sitting here who have worked on labor ward or working on labor ward have seen these kind of decelerations, and they come back to normal. And we are not surprised that at the birth of the baby has either a loop of cord around the neck or two loops or around the trunk, or we have to assume that the cord was getting compressed because the baby came out very well. So these are baroreceptor stimulated, which you don't have to worry about. The second types, which is the chemoreceptor mediated decelerations, are the ones which we may have to get worried about, because these are the ones which are activated by hydrogen ion concentration, carbon dioxide accumulation, and low partial pressure of oxygen in the baby. These cause stimulation of parasympathetic, and they also cause bradycardia. The difference between this and the earlier decelerations, which are baroreceptor stimulated decelerations, is that baroreceptor was mechanical cause. It was just stimulating or compressing the cord. The moment the cord is released, the baby is fine, the heart rate comes back to normal, it's at the normal baseline. But these are problematic because these are activated by hydrogen ion concentration, as I said earlier. So it is influenced by the chemical composition of the fetus blood. And therefore, that insult has to be removed by fresh flow of blood from mother. And that takes time. Therefore, there is a lag of the in the baseline and in the heart rate coming back to baseline. Now, chemoreceptor mediated decelerations are more likely in the background of uteroplacental insufficiency. And it also suggests that placenta is struggling to cope with increasing metabolic demands. The ratio between the placental supply and the fetal demand is not being met. And that is where the baby's heart rate is dropping, and it is taking time to come back to the normal baseline. And it may lead to hypoxic injury to the fetus. So there is a difference. Now, we know that when you look at pathophysiology, all decelerations are not same. You don't have to worry about decelerations, number one. Look at the decelerations. If these are chemoreceptor mediated, then you may have to worry. Now, quickly is something which is being propagated or I may say more introduced by this international consensus group of experts in obstetrics and CTG, intrapartum fetal monitoring group, where they have said that if there's abrupt deceleration, they're trying to move us away from the traditional CTG classification. I'll tell you about that in the next slides. So this abrupt drop in heart rate, which is more than 30 beats per minute, lasting 30 seconds, coming back to normal. These are compression, and therefore You don't have to worry about it. Tardy are the one which are more late deceleration kind of thing, where it may suggest uteroplacental insufficiency, and these are the type of decelerations which may not respond to your intrauterine resuscitation techniques like left lateral position and stopping oxytocin, giving tocolysis. Those kind of things will not work on these kind of traces. The again original classification which we are all used to is have variable decelerations which are further classified as typical variable, atypical variable. Now, typical variable are the commonest decelerations that you will see. It is intermittent mostly because of compression of the cord, and complicated ones usually drop more than 60 beats per minute and they last for more than 60 seconds. They may be biphasic pattern. You can see there a W pattern. Before the baby's heart rate, that deceleration, remember the cardioprotective effect, baby's heart rate is coming down. It's trying to catch up. It's trying to go and grab some more oxygen before it decelerates again. But even before it reaches baseline, it's again going back. That's a W pattern, which says that now the baby is probably decompensating. Its compensatory mechanisms are getting weakened. It is not able to get it. So you can see here, all those decelerations, baby is trying to conserve the energy, coming down, cardioprotective effect, quickly going up, grasping some oxygen, coming back again, trying to maintain the positive energy balance in the heart. CTG, the issue with CTG is that it has strengths. We all know it allows timely interventions. There are established protocols, there's legal documentation, and it is non-invasive. But there's a huge limitations as well. The limitations are it's subjective. We all know there is so much of difference in opinion about the CTG management. I mean, I've sat in best of the meetings with CTG with Professor Arul Kumran, Austin Ubumadu, and Edwin and Amar Bhide and Baski and all these people in one meeting. And we went through CTGs in those meetings and we were wondering how can there be such a big difference of opinion in management. So there are variation in interpretations. It is always easy to sit in the hindsight and say, oh, I would have done this, I would have done that. There's a huge false positive. There are papers which have shown that false positives with CTG can be as high as 99%. Now, can you imagine any medical tool or any medical investigation in practice, in such heavy practice, with a false positive of 90% or 99%? No, but CTG is still being practiced. And Cochrane review also has over time told us that it has increased cesarean section rate. It has increased instrumental, it meaning use of CTG, electronic fetal monitoring, has increased cesarean sections, has increased instrumental births. And all it has done is reduce neonatal seizures, but doesn't significantly lower the perinatal morbidity and cerebral palsy. Now, this particular paper is what I was talking about, which was published in September or October, I think, in 2024. This actually paper Edwin sent me himself when it was being, in fact, it was for review also he had sent when that was being published. Now, types of fetal hypoxia, when you look at, I'll come back to that paper in my subsequent slides. When you look at hypoxia the fetus has or is exposed to, there are 4 different types of hypoxias: gradually evolving hypoxia, subacute hypoxia, acute hypoxia, and rapidly evolving hypoxia. Now, an intact fetus with a previously normal CTG, which means the labor has started, absolutely normal CTG. When it goes through hypoxic insults, there is predictable pattern of fetal heart rate responses, which you should be able to predict what's going to happen next. So it's pattern recognition. You have to know, I'm seeing this, this is the story, I'm seeing this, what is likely to happen next? That is the whole point of understanding pathophysiology of CTG. Now, coming to the first one, which is gradually evolving hypoxia. Remember when I said about the fetal heart rate decelerations, I'm doing gymming, my respiration rate goes up and down, I take more and more oxygen. Baby cannot do that. What baby does is it reduces the workload on its pump, that is the heart, to maintain positive energy balance, and that is fetal heart rate decelerating to try and conserve the energy. Then what happens? It cannot increase the force of contraction. It has to rely on tachycardia. It increases the heart rate. So then next thing we see is the increase in heart rate of the baby. And then if at that point also the insult is still happening or the baby is not being delivered, then there is reduced variability, which can be a marker of decompensation of the baby, which means the baby's protective mechanisms, its defenses are now being shattered. Subacute hypoxia generally will develop over a period of 30 to 60 minutes. The fetus spends more time decelerating. So if you see that the baby is decelerating more and trying to conserve more and more energy, but at some point it has to come up to grab the energy and go back again. So there's less time spending at the baseline. This is very important. How much of time is baby spending at the baseline between the decelerations? That will determine the outcome, or that will have a significant influence on the eventual outcome. If there's lack of adequate time for the baby to get oxygenated, it's going to get in trouble. And the drop in fetal pH at the rate of 0.01 every 2 to 3 minutes is happening when these kind of CTGs are seen. Now, subacute hypoxia, TARDIS, which can be said as chemoreceptor triggered, are the ones which, as I said earlier, are influenced by the chemical composition of the fetus's blood, and therefore they may have influence on the outcome as well. So the brief interdeceleration interval, I just said about it, the interdeceleration interval is likely to have two consequences. It is insufficient to get rid of the fetus of carbon dioxide burden which it has, and the fetus is unable to raise its baseline heart rate anymore. And therefore the cardiac output will get affected and the baby will get into hypoxia and metabolic acidosis at some point. Look at the variability. Is it normal? We know that if the variability, so deceleration is done, acceleration, tachycardia is done, variability, if it is getting affected, you know that the baby is now losing its compensation. So look at the variability. Is it normal? Look at interdeceleration. Is it more than 60 seconds? If it is, then this fetus is compensating. Look at the stage of labor. Look at, anticipate, see how long is it going to take before the baby is going to be born. Third, acute hypoxia. This is single prolonged deceleration. So the drop of the fetal heart rate is less than 80 beats per minute, persisting over 3 minutes, then the baby can be in trouble. There are three non-reversible causes of prolonged decelerations. Do not waste your time trying to do any test or any investigations. Get on and deliver the baby. 3 are abruption, scar rupture, cord prolapse. These three suspected clinically. Don't waste time in CTG or interpreting anything else, or fetal blood sampling or all those things. If it is reversible, there can be hypotension, which can be because of sighting of epidural, for example, or a top-up of epidural. And excessive uterine activity is something which you will notice on the CTG, and clinically also. You have to then start intrauterine resuscitation measures by stopping the, say, oxytocin infusion and maybe give tocolytic. Prolonged bradycardia, there is a 3, 6, 9, 12 rule. 3 minutes, call for help, call everybody, inform your theater, inform your anesthetist. Interventions are left lateral position, trying to improve the oxygenation to the baby by giving tocolysis, stopping oxytocin, maybe starting a IV fluid. 9 minutes, if it is still persisting, move to theater. 12 minutes, prepare and deliver the baby. The rationale behind this rule is most of the babies, more than 90%, will recover within 60 minutes and 95% will recover within 9 minutes. So only the remaining 5% are the ones who will need delivering immediately. How will you predict that? What is the likelihood after a prolonged deceleration? The prolonged deceleration outcome will depend upon what was the baseline variability prior to onset of deceleration. Was this baby already decompensated? Variability in the first 3 minutes of deceleration. When for decelerating, during the deceleration phase, was there variability and was it good? Because variability is very, very crucial. We know it reflects the autonomic nervous system of the fetus. If fetal heart rate is maintained more than 100 beats per minute during a prolonged deceleration, the likelihood of acidosis is low. An acute drop in fetal heart rate less than 80 may indicate intrapartum hypoxic insult and may lead to rapid development of fetal acidosis. So I've already said this, so I don't think I'll have to. But again, it depends upon cause of deceleration. We have seen non-reversible, reversible causes, fetal condition before deceleration, and pre-existing placental reserves. What are the pre-existing placental reserves of the baby? Is it a IUGR baby? We all know that a term baby, which is low risk, absolutely well-grown baby, will tolerate the same hypoxic insult far better than a growth-restricted baby. So pre-existing placental reserves are very, very important. Now, when we know that this pathophysiology I have just talked about, but you are coming across a CTG where there's a rise in fetal heart rate and no antecedent deceleration. There are no decelerations, it's only acceleration, only tachycardia. Then that is not because of evolving hypoxia. It is not a gradually evolving hypoxia, because we know there are stages of gradually evolving hypoxia. You have to think chorioamnionitis. Is this baby infected? Because it's gone straight from one baseline to another baseline. There is no antecedent decelerations. And if the variability is reduced, there is no antecedent deceleration and progressive rise or acute fall in fetal heart rate, it is not associated with evolving hypoxia. Think of maternal conditions. So you have to take a step back, look at the whole clinical picture. It is one of the rules of CTG reading. You always have to have the background information about the obstetric story of the mother. I don't know about time. I'll probably quickly rush through because there's a lot to talk. So when you have a normal initial CTG, you know that this baby is neurologically intact. It is normoxemic, without acidosis or acidemia, and at low risk of intrapartum hypoxia, and is able to react and is equipped with all the defenses which it needs to deal with the challenges. But if the initial fetal heart rate in term is more than 160 beats per minute and has decelerations, reduced variability, particularly in association with meconium Steinleicher, then you have to consider whether this baby is fit to undertake the journey, whether this fetus is good enough to actually be allowed a normal labor. Because there will be situations where you will probably say, no, this baby doesn't fit the criteria to actually go through the stressful process of labor. Abnormal fetal heart rate pattern. Again, this paper I had written with Edwin. on saltatory pattern and sinusoidal fetal heart rate pattern. This was published in one of the peer-reviewed journals from European journals. It was Current Reviews. And this was only looking into saltatory and sinusoidal fetal heart rate patterns. Sinusoidal fetal pattern, it is noted in all these conditions, but for the sake of this talk, you have to know that fetal hypoxia and acidosis can lead to sinusoidal pattern. Again, it means that the baby is getting decompensated. Its compensatory mechanisms, its defenses are being shattered. So you have to act when you have this kind of situation. Now, severe anemia also can show you sinusoidal pattern, and there's virtual absence. You can see that there's virtual absence of CNS control over this heart rate. There's no control on the baby's heart rate from central nervous system. Pool sharp teeth pattern can happen with vasa previa. I've at least seen once in my lifetime. My colleagues, if they are here in the meeting, they will know from Hyderabad. We had a lady, we all were there. I was there, my colleagues were there, proper 9:30 or 10 a.m. in the morning. She started bleeding. We could not save the baby. Everything was so rapid. Even then, the baby we could not save. This was long back. But I'm just saying that fetal maternal hemorrhage can be very severe. It is because because of fetal hypotension, hypoxia of CNS, and instability of an autonomic nervous system. These things will happen, but you need to have the basic background behind when to be in a rush and when you have the time to wait. Saltatory pattern, again, this is something which is seen in less than 5% of labors. This essentially suggests that sympathetic and parasympathetic instability is leading rapidly evolving hypoxia in the central nervous system. Now, there is a new term which is being introduced, which is called zigzag pattern. This is more erratic and abrupt up and down fluctuations of baseline fetal heart rate. It lasts for at least it should last for at least 1 minute. And if it lasts for more than 2 minutes, then there's an 11 times increased risk of admission to an ICU. And intensity of hypoxic stress increases with insufficient time of baseline. You can see that there's no baseline there. The baby is just struggling to cope and gets any oxygen. This could be because of autonomic instability. Edwin had proposed this ABCDE approach where hypoxia begins. We all know now that after this talk, you will know that hypoxia, it begins with decelerations. Accelerations will disappear. This baby is trying to conserve all the energy. It's not wasting its movements and creating more energy need. Basal B is heart rate increase because of catecholamine release. Then the heart rate is still stable. Baseline is still maintained, which means the baby is compensating. When there is unstable heart rate, and there are changes in baseline variability, this baby is getting decompensated. And then if the baby is not even looked after by this point, then the baby may get into an end stage myocardial failure with step ladder pattern to death. So you can see the nature has designed it in a way that it gives you enough and ample time, unless it is one of those accidents where it is a scar rupture, abruption, or a cord prolapse. You have enough time to try and identify the baby. I'll skip this slide. Intrauterine resuscitation, oxygen, again, oxygen and IV fluids these days are out of fashion. The recommendation is don't give unless it is going to benefit the mother herself. Maybe she's suffering from sepsis or has asthma, for example, you can give it. Otherwise, there's no role for oxygen. Fluid also has a controversial role. I won't waste time talking about it, but stop tocolytics, maternal repositioning into left lateral position, and admission and administer tocolytics if you feel that the baby is having hyperstimulation. I'll skip this slide. This is about right. So very brief words about preterm labor. Now, the baseline heart rate in preterm babies at 24 weeks is around 155. Term is around 140. Once it crosses 40 weeks, at around 41, 42 weeks, the baseline even settles down to 120 because parasympathetic nervous system is more dominant at that time. And therefore, the heart rate is more towards lower side than the higher side. Whereas sympathetic is more dominant in the earlier stages. Therefore, the average fetal heart rate at 24 weeks is 155 as opposed to 120 at 41, 42 weeks. Accelerations can be seen at less than 30 weeks also, but the definition of accelerations is less than 10 beats lasting less than 10 seconds. It is not same as the one which we say about 15 beats. Variability is reduced in normally also because of immaturity of autonomic nervous system. So don't rely too heavily on making decisions in a preterm baby on variability because the autonomic nervous system is not very well developed. Remember that thing which I said about the interaction between sympathetic and parasympathetic nervous system? That's not happening. And that is not happening. Therefore, you don't have very good variability. So upon up to 75% of preterm fetuses may show intrapartum decelerations normally. Therefore, you cannot make decisions based on the standard features in a preterm baby. Now, baseline variability, lack of maturity, I've said, and there are three other things which are happening at preterm labor. There's decreased amount of LICA, there's reduced Wharton's jelly in the cord, and lack of maturity of myocardium. These may cause decelerations and higher incidence of variable decelerations. So you have to be very careful in taking decisions based on CTG. In fact, at 24 to 28 weeks, continuous monitoring is not recommended. Do not do continuous monitoring of fetus. You may do it for hearing the fetal heart rate, but don't do anything more continuous. 28 to 32 weeks, fetal monitoring may be considered. Survival and neurological outcomes significantly has improved these days, especially in most of the hospitals where they have better neonatal facilities. 32 to 34 weeks, yes, CTG can be classified according to guidelines used on term fetuses. But remember, this baby has a weak pump, a weak myocardium. So do not test these babies to the extent that you would in term babies. So keep that in mind when you're dealing with preterm babies. So what is new now? What are we trying to achieve when we are looking at new evidence? There should be a paradigm shift from pattern recognition. Pattern recognition meaning we're looking at the morphology of the CTG, looking at the decelerations and looking at the timing of decelerations, move away from that and look more into physiological interpretation of CTG to make CTG more relevant in clinical practice. Now, the birth of physiological interpretation, how did this happen? This happened from St. George's Hospital, where they had in fact decided that because of increasing perinatal morbidity and mortality, despite using the stand, despite using continuous electronic fetal monitoring, they decided to change the concept on and the way they looked at the CTG and bring in physiological interpretation. The interpretation to start with was based purely on application of knowledge of fetal physiology, which we have just spoken over the last 30 minutes or so, and the wider clinical context. So all that we have spoken until now is the fetal physiology, and put that in wider clinical context at what that particular lady. And the classification system, now the one which we have about early D cells, late D cells, typical, variable, all these terminologies should be done away with. And just put 7 parameters as opposed to 3 parameters of normal, suspicious, pathological. Because I'm sure there are a lot of people here who are sitting, may think something is suspicious, the other one may say, no, it is pathological. So do away with those things and classify 7 parameters. 4 types of fetal hypoxic stress: chronic, gradually evolving, subacute, acute. I have told you all 4 just some time back. 3 different patterns suggestive of central nervous system abnormality: zigzag, sinusoidal, and typical sinusoidal, atypical sinusoidal, pool chartic pattern. Now, these are the ones which you have to know. Forget about the normal, suspicious, and pathological. The aims of this physiological interpretation is to reduce unnecessary intrapartum operative interventions, totally eliminate the need for doing fetal blood sampling, and to reduce avoidable intrapartum hypoxia related to hypoxic ischemic brain injuries and perinatal death. This was the first guideline, international consensus guideline, which was produced in 2018. And after introducing this guideline in many centers in UK and abroad, there was approximately 50% reduction in rate of HIE and emergency cesarean sections after introducing physiological interpretation, which is what I've just shown. Now, sorry. So what this approach does is it eliminates observer variability, reduces variability in management, and it improved the consistent outcomes, improved and had consistent outcomes, which is what were the findings after introducing the 2018 guideline and having introduced this. So the approach differs from traditional random grouping of features into different categories like normal, suspicious, pathological, and so on. So evolving understanding and confidence in physiological CTG interpretation is what is needed. The whole drive is towards saying that clinicians should now move away from identifying the morphology of decelerations, but assess these 3 crucial factors: intervening baseline fetal heart rate for stability. Is the interdeceleration baseline normal? Is the baby spending enough time there? Is the variability normal? And is cycling seen? Following the success of introduction of 2018 guideline, they made changes based on the input, based on their experience, based on the feedback, and came up with this revision in 2024 with a new paper on similar lines. And they introduced two new things: feature suggestive of fetal inflammation, wherein there is increase in baseline fetal heart rate. So if the baby has started at a baseline of 130 and the baseline heart rate over time has gone up to at least more than 10% of its start, and there's no preceding deceleration, then this may be a sign of fetal inflammation. And these are the babies who may have increased interleukin-6 levels in their umbilical cord, which is a sign of neuroinflammation. And also the baby's admission to NICU is quite high in these babies. Now, the possible mechanism of fetal brain injury in these babies is completely different than the one which happens in gradually evolving hypoxia, for example. In those babies who are infected, or the mechanism of brain injury is by reduction in oxygen transfer across inflamed fetal membranes, and the myocardial dysfunction happens because of reduction in cardiac output, leading to reduction in cardiac output and reduction in cerebral blood flow. Remember when we started, heart, brain, two important things, both are being affected here in these babies. And therefore, look at the CTG. Is the baseline heart rate more than 10%? Is there no deceleration? If there's no deceleration, it is in a way bad news because it hasn't gradually evolved. This sudden zigzag pattern is seen and absence of cycling is there. The other thing which you have to know is about RUPI-L. This is another one which they have introduced, which is relative uteroplacental insufficiency. There'll be wide and deep decelerations as soon as regular uterine activity started, either spontaneous or secondary. We've seen many times that you start oxytocin infusion and the registrar says, oh no, the baby is decelerating and therefore we stop the oxytocin infusion and then it's normal now. The decelerations disappear and reduce the width and depth of contraction. This is where the intrauterine resuscitation I'm talking about. Baby is telling you that now I'm not able to cope. My compensatory mechanisms are kicking in. I'm decelerating, getting oxygen, coming back to normal. Now you've stopped it. Now I'm fine. I'm happy, which means I'm not liking the uterine contractions. So that is where this terminology is important because there is a relative deficiency in the ratio of placental supply and the fetal demand. So these are not matching. And therefore, the baby is decelerating and remains decelerated and then comes up just to grab some more oxygen and go back again down. Last component of this talk, artificial intelligence in CTG. Now, are we talking about artificial intelligence? Yes. Again, feel proud of saying that my friend Edwin has introduced this Teresapp. This app has actually is derived from the word Theoris and it is a Greek name for the hippo-like goddess in charge of childbirth protection in Egyptian mythology. Now, this he developed in teams with from various other countries. And what does, sorry, this is based on information which has fed to this app. Types of fetal hypoxia is based on physiological interpretation. So the old, I'm saying old, but it is not yet old because all the recent guidelines, all the guidelines which we standard follow are the same now, but it will change in future based on the physiological interpretation, which I've just spoken for last 40 minutes odd, I don't know. So, and this app is continuously being upgraded based on the submission of data from clinicians and several hospitals from Europe, Asia, China, and Middle East countries to continuously improve its accuracy. This is available now for free, as he told me, and I've actually downloaded it on my phone, on Android as well as on Apple phone. This is Teresapp. All you have to do is take a picture of the CTG, crop it to keep the fetal line, and you get expert diagnosis. It will tell you straight away what the diagnosis is and what the management advice is. There you can see the example. The prediction, it says gradually evolving hypoxia, decompensated, and it tells you how certain it is. It says certainty is high, certain, almost 100% certain. And then it says management prediction. Now, if you have questions, you can have a chat with the bot as well. It will chat. You have some query, you ask, and it will answer you as well. So this is the app which is now, and they have looked at the validity of this app. Is it really going to work in practice? So there was this research article, which was, I think, this was January this year. It was published, wherein the conclusion was there was substantial agreement between the editorial board members who are all experts in CTG from various countries. And this study was led by Edwin. And these findings highlight that the potential of AI-assisted tools based on physiological CTG interpretation provides expert-level diagnostic accuracy in clinical practice. So this study actually, through 100 CTGs randomly selected to the expert. In this case, he was the lead author. It went to the lead author and then to the Teresapp. So overall diagnosis, the independent expert gave his own opinion, and the Teresapp came up with its own opinion. And the agreement as far as diagnosis was concerned was 94% between the two of them. And the recommended management, when it came to it, was almost 98% agreement between the expert and the app. So the summary, to summarize the whole talk, you move away from morphological classification of CTG, interpret them more physiologically, and assess the intervening baseline fetal heart rate for stability. Reassuring variability and should be there, and cycling must be there to determine fetal well-being. So remember that an intact fetus with normal CTG will exhibit a predictable set and sequence of fetal heart responses. We can predict as to how this baby is going to behave. So it's pattern recognition. Don't look at the CTG. You should now have the knowledge enough to say what is going to happen next. I know, based on the clinical scenario. May not always be true, or may not always come right. But you should now be in a position to say, yeah, I think this is what is going to happen next. And deceleration should be viewed as a fetal reflex response to conserve energy. And not all decelerations need intervention. And consider the overall clinical picture while interpreting CTG trace. So I think I have finished. Thank you.
I think, Dr. Niraj, you have In Hindi, we say Gagar mein Sagar. You had 10 minutes more, but you have finished it very nicely. But stay on
Oh, I thought
because
I overran. Sorry, I could have spoken for more. I skipped some
no, you
slides.
can take a breath and start again. No
No, no,
worries.
because I was rushing through towards the end because I thought maybe it's unfair on the
Yeah.
on
So
the
there are questions, and so there is one question explain about cycling. So okay, take that shot. And
explain about cycling.
dear
Yeah.
friends, do not go away because the second part of this session is the actual exercises of CTG, where Dr. Rinku will be taking us through cases and CTGs. And then Dr. Niraj and Dr. Rinku are there, and along with seniors, I can welcome Dr. Manju Puri, Dr. Aruna Nigam, Dr. Manjula Rotagi, Madam, Suman Bishnoi, Madam, and Dr. Geeta. A lot of seniors are also here. So it'll be nice, interesting thing. So, okay. Or I think Dr. Rinku will explain. Dr. Neeraj, she will be taking up cycling also.
Yeah, yeah.
So,
Let
okay.
explain.
Yeah.
Fine.
Okay. Welcome again, everyone. And we are back to the labor ward now from the lecture theatre. And uh, I'll start with reiterating what Dr. Neeraj said, that, most babies do very well. They are fit for the trek. And we have to identify the babies who are not ready for the labor trek. And how do we identify them? We are talking about cyclicity, cycling. And so this is a baby that I caught in the labor ward who showed me all the three phases, behavioral phases. You can see the deep sleep phase, and then you see the active wakefulness phase, and then you see the active sleep phase. So when you see a baby with all these three features, you know that this baby is a good baby to start with. And most of the time, we cannot make out three phases. Usually, we are able to make out two, and that is good enough. So, I think that answers the question of one of the um, participants. So, this is a baby whom we found not to be fit for the labor trek. And this is a CTG which I think Dr. Neeraj also shared. And again, this baby had fetal anemia due to feto-maternal hemorrhage. So, this picture has to carry on till 40, 50 minutes before you start worrying. But you see, this particular mother, we started worrying because she was saying absent fetal movement. Now, for a mother who says absent fetal movement, you don't really have to wait for 50 minutes. Maybe you can do an ultrasound and you can get going, or sometimes even straight away start discussing with the relatives about the plan of care. Now, this is an interesting CTG. So, this was shared by Dr. Meenakshi Banerjee. I'm very grateful to her from Rainbow. So, this is a mother who had went tachyarrhythmia. And I think this mother just came in for a routine checkup and found to have a very high fetal heart rate. And this baby needed digoxin in utero. And finally, a fetal echo was done. And I think the baby did well later. But this is a very unusual thing that you may sometimes find. The fetal heart was around 250. The variability was there. But of course, these kind of babies, you have to do a C-section because you cannot monitor them with CTG. So, talking about cyclicity again, now you look at this mother, she came to me at 40 weeks. I mean, she was there with us, following with us all along, appropriately grown and everything. And at 40 weeks, she came for induction. And you look at her CTG, you will really have to look close. When you look at it closely, it looks fine. But this the baby never showed cyclicity. However, it looked all right, the variability was fine, and so we induced her. And once we induced her, the CTG started showing these variable decelerations, and they got worse. And finally, when we did a ARM and found meconium. So the absence of cyclicity should ring a bell in our mind. Now look at this particular mother. She was a multigravida, complained of some decreased fetal movements. We did a NST, and you can look at the first part of the NST. The baseline is not stable. A little part is showing a bit sawtooth pattern, I would say a pseudo-sinusoidal, and we start worrying. But you look at it closely, this mother has marked multiple movements, and that makes me happy And when I sit on it and carry it on the CTG, the NST becomes fine. So sometimes expectant management is what we need. But of course, we have to look at the background and look at the mother as a whole. So this admission chronic hypoxia checklist has been discussed by Dr. Niraj, and the emphasis on cyclicity, cycling, and variability in the beginning of the labor is emphasized and re-emphasized, but never we should miss the wider clinical picture. And that is why I started with the CTG in the beginning. And I said, if you miss the wider clinical picture, you will either over-intervene or under-intervene. Now you look at this case, I think some of you may have seen it has become viral by now. And this is a mother who came with previous cesarean in Sitaram Bharti, I remember, and she never told us any, less fetal movements. And the doctor there, the junior consultant, like the nurse puts the mother on the CTG straight away without examination sometimes. And this is what we find. And actually, this mother had a macerated fetus. This is the maternal heart. And therefore, the lesson is that we should never miss writing the maternal heart rate on the CTG graph ever. You can see on this first part how closely the fetal heart and the maternal heart is mirroring each other. The other thing is the speed. You can see how different the graphs look when this is at 1 centimeter per minute and this is at 3 centimeter per minute at the same time. So what you should always go back and look at the speed. Most of us are using 1 centimeter per minute, but some in Delhi are still using 3 centimeters. So you should know what you're comfortable with before interpreting. So now you have given the baby the green signal to go for the trek. But there we have to handhold the baby all through the journey. In the latent period, there are some delicate ones, who will give up soon. Now, this is a mother who came to us with decreased fetal movements again. And in early labor, she was showing this kind. I mean, she came to us in early labor, and right from the time that we started monitoring her, this is the picture that we found. And we know that by now, that if this is the picture which is going on for more than 40-50 minutes, something is wrong. There is a depression of the central nervous system, like Dr. Neeraj has emphasized and re-emphasized. Now, this baby actually had a meconium aspiration, in utero meconium aspiration, and came out with poor APGAR, but finally the baby did well. So constant vigilance as the trek gets more difficult. One of you have asked this question that, if there are recurrent decelerations, very clearly, like Dr. Neeraj has told us, this is a baby who is having subacute hypoxia. The deceleration, so with a reasonably good baseline, and then suddenly these decelerations have started. Now, this is a picture I think a lot of us have come across with high use of oxytocin. And suddenly, sometimes, of course, this mother was not on oxytocin, but she had got misoprostol 4 hours back. And you can see that probably the contractions are too many and too intense. And in a situation like this, when the labor is advanced and you feel that this baby was a low risk baby from the beginning with good reserve, the previous CTG was normal, you could give a shot of tocolytics. We could use glycerine trinitrate sublingual puffs, or whatever, because terbutaline is not available. And you see how the CTG improved, although it was quite bad. The variability was drastically less, but then it got better and the mother was fully dilated. And of course, asking the mother not to push is also very important. So whatever reversible hypoxia, whatever you can do for the reversible hypoxia, you must do. Start intrauterine resuscitation. Of course, keeping the OT ready. Some of these mothers will need cesarean section, but this one didn't. So bad weather, changing landscape can happen anytime. Hyperstimulation is one such thing, but there are others. We know that rupture, cord accidents, these are irreversible hypoxia. You can't fight. You have to do a C-section, and quickly too. And this is a mother where she was in early labor with previous cesarean section, and you can see how the contractions have increased in this part, if we were to believe the TOCO. And then finally, the CTG is showing this drop in the baseline some variability still preserved, and then finally a bradycardia. Thankfully, we did a cesarean section on time and she had a rupture, but the baby did fine. But these are real difficult situations, and one has to be really vigilant for a case of VBAC because things can suddenly go wrong. And finally, when we come to the second stage, a lot of us feel, oh, the mother is fully dilated and now our worry is over. But I think the real worry is in the second stage. And intensive nursing monitoring, intensive work is needed for second stage, especially in the prime gravidas. We must be very careful about our oxytocin. In fact, we should reduce our oxytocin in the second stage. Now, this is a mother where you can see how the hypoxia was evolving. The baseline increased, like Dr. Niraj taught us just now. And then gradually the decelerations happened. This baby, you know, uh, lost variability. You can see the progressive autonomic dysfunction that is happening. And while the instrumental was getting ready, it seemed as if the CTG became better, but actually it was the maternal heart rate which was being picked up. So finally, we have reached the summit. And once we reach the summit, our work is not over. For all those labors where we feel that, we did something which we were not sure, or there were some CTGs in the gray zone, I think we should take paired cord blood gases and we can retrospect and reanalyze the management that we did in the first and second stage of labor. So I think doing cord blood gases is also something which should be incorporated in our protocol. So concluding, I will conclude with this book, which Dr. Mitra has shared with all of us, and we ended with reflection. Cord blood gases is one way that we can reflect our labor care. So regular self reflection and self introspection will allow us to grow in this field. And I think sharing and learning other CTGs, whatever CTGs we all have, we should have a common forum where we can share and learn with each other and grow. And I'm really thankful to Dr. Mitra for giving us this opportunity to share such a lot of these CTGs, which I think some of the doctors I'm very grateful to them who shared with us, and we all learned in the process. Thank you so much.
Thank you so much, Rinku. So this is very nice mnemonic. Why don't you say it?
Yes. Sir, you want to say? Sir can conclude, I think.
No, this
Please.
is something which again was there in one of the presentations, papers which I had,
Yes.
which again this group of Edwin had propagated. Is this fetus fit to take the journey? So
Right.
have to evaluate, and that is where Rupi L, that the relative uteroplacental insuffficiency comes in, wherein you look at the checklist. I think you showed the checklist earlier, whether
Yes.
the baby's heart rate is normal. So if is this baby normoxemic, is the cycling present, all those features. And then if you feel that yes, it checks it, then you allow the baby to travel the journey. If you feel no, it is not, then you go back. And there's a nice mnemonic: fit for labor, evaluate risk factors. Again, one important thing which I don't have to tell, I'm sure all of you know. I'm sorry if I'm saying something very basic, but we have to look at the overall clinical picture. Don't glue yourself to the CTG and say, oh, this is what I'm seeing, this is what I will do. Take a step back, eyeball, look at what has happened earlier in the CTG, not this piece of CTG which you're showing me. I want to see what has happened before, if you have, and the clinical picture, and then look at the whole global picture and take a decision. So that is something which we all, I'm sure, are already doing. So type of ongoing stress, hypoxic, inflammatory, or other. And others may, inflammatory is very important. Choriamnitis, the way the baby is affected, that mechanism is completely different than the hypoxic insult. So those babies can get affected very easily. They can have a capacity to cope to a certain extent. After that, they immediately deteriorate. So take action in a that brief window which baby allows you to bail it out. Sorry. As a central option, very good labor progress and overall clinical picture. Yeah, that's what it is. Thank you. No, thank you, Dr. Mitra. It was a wonderful.
We are not yet going. There are a lot of
sorry,
questions. And we have seniors also. They have also, Dr. Manju has also given one mnemonic. I'm going to invite her. I want to add just two things from my side. One thing is that people asked cycling again. So I would like to make it more clear that as an obstetrician, we have to know it's not start stop. The labor starts and it'll end as, baby will be delivered. No, the baby has to go through that journey of all those movements in utero and through the pelvis and all that. And it is such a royal personality that the baby will still sleep, be awake, sleep during those 8 hours, 10 hours, 12 hours. So cycling is a the graphical representation of the sleep cycle of the baby, wherein there will be a period of deep sleep where there is no variability, very little variability. Then there will be active REM and there will be active awakening. So this is, I think, if I'm not wrong, that whole thing takes around 70 minutes. 70, 60 से 70 minutes. So this will happen intermittently. So we may pick up these in between also, and we should not be afraid, like Dr. Niraj and Dr. Rinku has said, that we should take a longer graph if we are getting confused whether this is. So cycling period is a physiological phenomena, it's not ominous. And if a baby is showing cycling, the baby is fine, because there will be period of REM where there will be acceleration, like नीरज वेरी वेरी क्लियरली सेड, बच्चा ठीक है तो हिलेगा, और हिला है तो इसका मतलब उसका हार्ट ठीक है, वो हिल रहा है. So that is one thing. Second thing I wanted to add, Dr. Neeraj and Dr. Rinku, that nowadays, because all the bigger places are offering epidural anesthesia, so there again the monitoring of a baby and interpretation of graph is extremely important, because there in epidural anesthesia, when you're given a top up or you've just started the epidural, there could be features of hypoxia. Dr. Neeraj, please correct me if I'm making any mistake, that during epidural, lot of wrong decisions can be taken if the graph is not understood correctly. So anybody who's using epidural and CTG can highlight that. And then also I would like Dr. Manju to elaborate on fit cat. She wrote FITCAT. So Dr. Manju, please unmute yourself. Amit, we can make this stop share kar do Rinku aap.
Okay.
And friends, today's lesson was also very nice. That introspect. So CTG is one thing. Every obstetrician must introspect. Where do we stand in interpreting our baby's graphs? Dr. Manju.
So, Mitra, I think great talks by Dr. Neeraj and Dr. Rinku. Very, very clear and very informative. So, this FitCat also comes from the Edwin's, it is also a tool advised by the same group, the consensus group. So, this actually is a short form acronym. F is for fetal disorders, I is for, I'll just tell you. Basically, I is for intrapartum risk factors, T is for tone enhancers, and C is for choriamnitis, A is for adverse maternal environment, that is fever, dehydration, etc. And T is the treatment the patient is getting. So basically, it is kind of looking at all these factors and keeping them in mind that they can have effects on the CTG. I think that is what it is, given. But I think that's a beautiful article which everyone must read.
Yeah, and being an obstetrician, it's not in that one point of time. It's a dynamic process. So, while we are monitoring, the baby will be, going through the process of labor. So we have to take in totality where what is the stage of labor, engaged है कि नहीं, contractions कैसे आ रहे हैं, do we have to induce, or we have to augment or not. So everything has to be taken into.
जो थोड़ा चेंज जो हमें अब फोकस करना है वो ये है कि व्हेन द पेशेंट इज कमिंग, व्हेन वी डू एडमिशन सीटीजी, उस टाइम पे बेसलाइन देखना जरूरी है, उसकी वेरिएबिलिटी देखना चाहिए, उसकी स्टेबिलिटी देखना चाहिए, और उसके बाद व्हेन एवर वी आर रीअसेसिंग, सो वी नीड टू रिव्यू ऑल दीज थिंग्स अगेन with that baseline. That comparison we never used to do. Oh, standalone, and then how much time is the where this decelerations के बिना जो time है, उस baseline पे I think ध्यान देना is more, and cyclicity is, these are two things which
मेरे को भी यही सबसे अच्छा लगा है कि instead of focusing on the decelerations and all, two things. One thing is baseline अगर अच्छा है, इसका मतलब बेबी का हार्ट वापस आ गया. दूसरी चीज द ड्यूरेशन, हम हमेशा याद करते थे 3 मिनट 6 मिनट्स में, एस्फिक्सिया भी तो 3-4 मिनट का ही होता है ना. So any deceleration, if it's more than 3 minutes, is going to be omnious. So you can't sit tight on that. So it is actually made things very, very simple. And I think Dr. Neeraj, all your slides which you ran through, everybody would love to sit down and read. And let me assure all the attendees that all the recordings of all our sessions are going to be very much available. Please don't become anxious and nervous. They are all going to be in public domain. Only thing is that 4 more sessions, so please keep joining live.
No,
And
one second, if I can just quickly come in. In the chat
please
box, I
come.
read one of the question about fetal blood sampling. I skipped that slide because of lack of time, I thought. It's very important question, fetal blood sampling. Two things you have to make it very clear. One, when the fetus is hypoxic, we all know it's going to shut down its blood supply to the peripheral organs, which includes skin, gut, scalp. Now, by taking a scalp blood sample, you are taking a sample which baby has deliberately shut oxygen supply down. So you are going to do a lot more cesarean sections. It's not going to give you a true picture of what's happening in the brain, because the brain is being protected and scalp is being compromised. You're taking sample from scalp and saying, oh, it's hypoxic, I'm going to do cesarean section. So you've done cesarean section for thousands and thousands of millions of women globally based on fetal blood sampling, which was always wrong because of the fact that that was a wrong sample you took. Second, the scalp is supplied by external carotid artery. The brain is supplied by the internal carotid artery. So you're taking sample from a wrong place. You're taking sample from external carotid artery and making decisions of what is happening on the internal carotid artery in the brain. So those two reasons, fetal blood sampling is completely out, should have been out long ago. But now this consensus group has said, I think the latest NICE guidelines also has said fetal blood sampling should stop and it should not be practiced anymore. For these two reasons, I hope that is very clear.
And in
that is for the scalp pH. I mean, cord blood
Yeah.
gases is different.
Sorry, I'm
This
talking about
is what
scalp.
sir is.
No,
I
Diraj,
don't
There was
know
a
whether the
question about
question
scalp pH.
no, scalp.
scalp
I'm telling
pH
you
is
scalp.
different.
Yeah,
Scalp
And
no,
you're
pH
very
is
right, Rinku. The cord blood sampling is to be done basically again as a
Mhm.
medico-legal correlation, especially when the
Yes.
baby's APGAR is low and you have a cord
Mhm.
blood pH and all that to substantiate that whatever your monitoring was or XYZ. So
Mhm.
that is different. You very nicely pointed out. Then another thing that now it's gone off my mind. Something I
Dr.
wanted to say.
Mitra, Dr.
Yeah,
Geeta Balsarkar here.
yeah.
I would
Yeah.
like to say that I give a lot of importance to mothers complaining of decreased fetal movements.
Yeah, we are.
So
Yes,
some of
yes.
the mothers are very, very sensitive. And if they say that there is decreased fetal movements, then even if the NST is borderline or it is reactive, then we have to interpret it in a different perspective.
I personally, Dr. Geeta, because I have a color Doppler and itna मैंने जरूर सीख लिया है. So all these patients who come up with decreased fetal movements in the antenatal time and the CTG is not very reassuring, I don't send them back without seeing the CPR myself. I see the color flow. When I'm sure that the fetal oxygenation is good and it's mother's nervousness, then only I reassure. Otherwise, we have to
Madam,
take a call upon.
we can use Doppler even intrapartum. We
Yeah,
can use
yes,
ultrasonography
intrapartum
even
Doppler and
intrapartum
intrapartum
to
ultrasound.
evaluate.
Yeah.
Yeah.
So that is, but
I
actually,
think
only those who obstetricians who have the liberal thing of having an ultrasound, they can bring it in and do it. Otherwise, that is a little bit logistically a little bit troublesome.
I think, ma'am, every institute, every labor ward should have their labor monitoring protocol. Somebody is asking how many times and how long you should see. I think we should clearly, write how many times in low risk, how many times in high risk, so that people are clear and nurses are clear for monitoring.
I personally get a intermittent. If I put a patient for induction, I do not give like whether it is a mesoprost. I don't give it earlier than 4 hours, but every time before the mesoprost insertion, I for myself, whatever the guidelines say, I definitely look at the CTG. So I know abhi patient bachche ka kya haal hai. Your presentation of how fit is the baby and Dr. Neeraj's talk. It has given me so much of insight that so many primaries I've been able to deliver without tension. Delivery तो हम vaginally कराते हैं, but फिर वो अब की everything is fine. This baby is fine. So just keep that in your mind and it really helps you. Thank you. So, shall we call it a day?
Sure.
Yes, Dr. Mitra.
Thank you.
Happy Doctor's Day to all of you.
Yeah,
Thank
happy
you so
Doctor's Day
much.
to
Thank you.
everybody, all my seniors, all my friends, colleagues. Manju, a big hello to you from Niti's house. ये नीति के
Thank
घर
you.
में बैठी कर रही हूँ. And thank you. I'm so happy that we had so many people. And Niraj and
Thank
Rinku,
you.
you
Wonderful.
shone like bright
Thank
stars.
you.
And I
Thank you.
invite you for our 7th session on 8th of
Excellent.
July.
Mitra, excellent presentation by Dr. Niraj and Dr. Rinku.
Huh.
And you are looking beautiful.
And I'm very happy. I could see Vedai has come in. Rinku Vedai
Uh,
had joined. Our moderators are
Okay. Okay.
mm.
Thank you everyone for
Okay, thank
coming
you.
and joining and
And
actively
lovely comments.
participating.
Everybody को खूब मन से डॉक्टरी करो यार. इससे अच्छा जन्म नहीं मिल सकता.
Thank
नहीं,
you,
वो
Dr.
तो कर ही रहे हैं.
हाँ, सब कर रहे हैं
ठीक
तो
है,
chance to-
happy.
okay.
Thank you, Dr. Mitra, for giving me the chance to present, and it was a
Yes.
pleasure. And
Dr.
thank you, Rinku,
Neeraj, you
also
have
for
become a
moderating.
very
And
popular
thank you.
person in Foxy and in north of India.
Yes, thank you.
Hmm.
All thanks to you.
Celebrity. Thank you.
Thank you.
Thank you
Bye.
Bye-bye.
everyone.
It was wonderful.
Bye-bye,
Bye.
ma'am.
Thank
Bye
you.
Bye,
bye.
ma'am.
Bye
Thank you.
bye.
Bye.
Thank you,
Bye.
Amit. Thank
Bye.
you, everybody, for logging in, all my team. And bye-bye. Have a good day.
Bye.